Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Chris Dagher and Dr. Nadeem Abu-Rustum, who are both in the Department of Surgery, Memorial Sloan Kettering Cancer Center in New York City. And the topic for this discussion is going to be the article titled "The Effect of Substantial Lymphovascular Space Invasion on Location of First Disease Recurrence in Surgical Stage 1 Endometrial Adenocarcinoma." Chris, Nadeem, thank you so much for accepting our invitation and welcome to the podcast.
Thank you so much, Pedro. Thanks for giving us the opportunity, and thanks to Chris for all the work. Pleasure to be with you.
Likewise. Thank you so much for having us.
Absolutely, of course, a pleasure for us. So, Nadeem, let's start with you. Can we start by discussing what was the reason for actually carrying out this study, and why do you consider this is a relevant topic today?
Thanks, Pedro. So, historically, LVSI was reported as present or absent, detected or not detected. But over the last 10 years or so, the concept emerged that quantifying the amount of LVSI is important. And that has evolved to counting a certain number of vessels. Most of this data came in patients who were not surgically staged, and then created this idea that LVSI only matters if you reach a certain threshold. In other words, if there was a small amount of LVSI, it was almost equivalent to not having LVSI. So this really created a new concept for us to study. Most importantly is because this new definition of extensive or substantial LVSI entered into clinical guidelines, and in 2023 entered into the FIGO staging to upstage patients. So it was really necessary to provide data on surgically staged patients to really study this. Is it absolutely accurate, what was proposed?
Thank you for that introduction, Nadeem, and I think certainly there will be some follow-up questions in the podcast later on, so that we can address specifics on that as well. But I wanted to turn to Chris and ask if he could talk to us about the methodology of the study and what were some of the inclusion criteria for the patients evaluated in the study.
Absolutely. Thank you so much. This is a really interesting methodology that we used. This was a multi-institutional retrospective collaboration between our center, Memorial Sloan Kettering, and the Oslo University Hospital or Norwegian Radium Hospital in Norway. We have decided to include patients that were treated between 2012 and 2019 who had FIGO 2009 stage 1 endometrial cancer and underwent full surgical staging that included hysterectomy and lymph node evaluation of at least the pelvic lymph nodes. And we wanted both the pelvic lymph nodes bilaterally to be evaluated and negative. To ensure that we are studying a uniform group, we excluded patients with positive lymph nodes, including those with isolated tumor cells, as well as those with incomplete nodal assessment, in addition to patients with positive peritoneal cytology or those who had synchronous ovarian tumors. The key variable of interest for us was lymphovascular space invasion, and we categorized it based on the extent of lymphovascular invasion as defined by WHO, with involvement of 5 or more vessels on a single pathology slide, defining substantial invasion. And what is between 1 and 4 considered as focal, and no lymphovascular invasion being none. A pathology review was carefully conducted by expert gynecological pathologists in each center to ensure consistency, especially for cases with suspected lymphovascular space invasion. We used competing risk analysis to better account for events like death from other causes, and we incorporated adjuvant therapy as a time-dependent variable in a landmark analysis.
Now, Chris, what are the primary outcomes and secondary outcomes of this study?
So our primary outcome was the 5-year cumulative incidence of both local or distant recurrence. We wanted to understand how recurrence patterns varied based on the extent of lymphovascular space invasion using those parameters. And our secondary outcome focused on identifying which factors were independently associated with either local or distant recurrences. And to do this, we used multivariate competing risk models that accounted for other established risk factors like tumor grade and depth of invasion.
So now, Nadeem, I wanted to turn to you because you brought this up previously and you talked about the classification and certainly, obviously, Chris, you also talked about your evaluation of lymphovascular invasion. But how reproducible do you think is the classification of focal versus substantial LVSI across different centers? What's the level of pathology expertise that you have to have in order to be able to really have consistency and accuracy?
Yeah, it's an excellent question, Pedro. And the diagnosis of LVSI can be challenging because there are mimics to LVSI, and pathology literature and expert GYN pathologists do bring this up quite a bit. So I think fortunately with this increased interest in LVSI over the last few years, particularly beginning in with the introduction of the quantification into clinical guidelines and staging, expert GYN pathologists have put a lot more effort to try to standardize this. But I think at the moment, if you look globally at the diagnosis and quantification, I would suspect that there is significant variation in the diagnosis and reproducibility. And that's another reason why we need to be careful when this concept is still evolving and not completely defined and standardized, to put it into clinical guidelines and to put it into staging systems.
Absolutely. So we're actually going to address that as well in the upcoming questions. But Chris, I wanted to turn to you to go over the results of the study. What did you find? What are the points you would really like to highlight for our listeners?
Definitely. I mean, we included a total of 1,555 patients, and we found that of those, 88% had no lymphovascular space invasion, 8% had focal, and 4% had substantial lymphovascular space invasion. The median follow-up we had for the study was just over 5 years, and about 21% of our patients received adjuvant treatment, whether in the form of intravaginal radiotherapy or chemotherapy, depending on institutional practices. We observed 173 events, including 56 local recurrences and 43 distant, in addition to 74 deaths without recurrence. When we looked at the 5-year cumulative incidence of recurrence, it was significantly higher in patients with any form of LVSI, which was about 19.5% for those with local invasion and 19% for those with substantial invasion, compared to just 6% in patients with no LVSI, which makes it about a rate of 3-fold increase for any level of LVSI involvement. On the other hand, in univariate analysis, the recurrence patterns differed by extent of LVSI. We noted that focal LVSI showed a balanced increase in both local and distant recurrences, and whereas substantial LVSI had a clear skew towards distant recurrences. This was further confirmed within our multivariate competing risk analysis model. On the other hand, and in terms of our secondary objective, we also reaffirmed the importance of classic risk factors like tumor grade and depth of myometrial invasion as significant contributors to recurrence risk, especially amongst patients with substantial LVSI. In this group, high-grade tumor and depth of invasion were more commonly seen, amplifying the overall risk profile.
So now let's get into some of the questions from our fellows in the journal. And this question I'll address with you, Nadeem. Julia Gellison, University of Wisconsin-Madison, she's asking, the other studies that you cite evaluating the role of focal versus substantial LVSI all use different cutoffs for these categories than the WHO criteria used in this study. In addition to your study, is there any other evidence to suggest that this definition provides better prognostic stratification?
It's an excellent question, Julia, and it's important to point out that the WHO definition of substantial LVSI, 5 or more vessels, was not based on publications or data in surgically staged patients. It was a consensus definition. As you mentioned, multiple papers have used different definitions, anywhere from 1, 2, 3, or 4 vessels. So the manuscript that we prepared from this collaboration with Norwegian Radium Hospital, University of Oslo, that was published last year in the same journal, and this publication are the only 2 papers that I'm aware of that take surgically staged patients with negative nodes and uses the WHO definition. And we don't have any other evidence that I'm aware of at this moment.
Now, Chris, this question comes from Christian Brown in Lucerne Cantonal Hospital. And he's asking, in the substantial LVSI group, systematic lymphadenectomy was performed 2.5 times more frequently, while sentinel lymph node biopsy was used less often compared to patients with no LVSI. So what do you make of these findings?
Thank you, Christian, for this very interesting observation. And for really looking into our numbers. This observed a higher rate of systemic lymphadenectomy and lower use of sentinel lymph node in patients with substantial LVSI. We feel that it likely reflects institutional national practice patterns rather than a direct causal relationship with LVSI itself. We have to note that a significant proportion of patients with substantial LVSI in our cohort received care in Norway, where systematic lymphadenectomy remained the standard approach through 2019. And although SLN mapping began gaining traction in Europe during the mid to late 2010s, its adoption varied widely across countries and institutions. And in Norway, and this is based on a conversation with our collaborators, big shout out to Dr. Erickson and Dr. Trent. The implementation of SLN mapping was relatively limited during the study period, which likely contributed to the observed differences in nodal assessment strategies across the LVSI subgroups.
So now, Chris, a few more questions for you. This one comes from Manuel Montesinos Albert in Valencia, Spain. And he's asking, given that patients with substantial lymphovascular invasion exhibited a higher rate of distant recurrence compared to those with focal or no invasion, what biologic mechanism or tumor characteristics might be promoting hematogenous dissemination in that group?
Thank you, Manuel, for this really important and thought-provoking question. Substantial LVSI likely reflects a more aggressive tumor phenotype, which is further substantiated by its coexistence alongside grade 3 and deep myelinvasion. While the exact biological drivers remain to be fully elucidated, several possibilities may account for this pattern. On one hand, substantial LVSI may signify higher chance of true vascular involvement, offering tumor cells more direct access to the bloodstream and distant organ sites. Additionally, tumors with this extent of invasion often suggest a more invasive and mobile phenotype, potentially related to changes in the tumor microenvironment, angiogenic signaling, or interactions with the immune system. These associations, while still under investigation, underscore the need for further molecular and translational research in this field to better characterize the pathways involved in distant metastasis of the subgroup of patients.
Now, this next question comes to us from Kira Fischer. She's at the University Hospital in Heidelberg, Germany. She asked, what do you think is the strongest risk factor for distant recurrence? LVSI, grade 3, or death of myometrial invasion?
I hope I'm not going to be angering a lot of people, but I'm going to base my reply based on our findings. In our multivariate competing risk model, tumor grade followed by depth of myometrial invasion demonstrated the higher risk estimates for recurrence compared to the extent of LVSI, both on the local recurrence side and on the distant recurrence side. And from existing research, we do know that deeper myoinvasion, particularly involving the outer third and grade 3 histologies, have been found to be highly and tightly linked to distant metastasis. So, there's a lot of missing pieces in the puzzle, but hopefully more research that is more standardized and aligns together can lead to the exact answer.
This question comes from Matteo Marchetti in the University of Padua in Italy. And interesting observation. He notes, how do you interpret the nearly identical percentages of grade 1, grade 2, and grade 3 in the substantial LVSI group? Was this an expected finding, or does it come as a surprise considering the differences in tumor grades observed in the no-LVSI and focal LVSI?
Definitely. Thank you so much, Matteo, for this question. We do know that, based on our research, substantial LVSI appears more frequently in tumors with high grade and deeper myeloid invasion. If we track the proportion of substantial LVSI of a grade 3, across the three different subcategories, we saw that this is an incremental increase in grade 3 tumors as the more extensive the LVSI is. And it has been shown before that LVSI grade and endometrial invasion go hand in hand. So we were really particularly interested to see and explore how these parameters will be distributed across the different LVSI subgroup. And we were pleased to see that this association was reflected in our final analysis. Now, the question remains, if substantial LVSI is only associated with grade 3, why are we seeing grade 1 and grade 2? I don't think it's only associated with grade 3, but it is more associated with grade 3 tumor than grade 2 and grade 1.
So now I'd love to hear your thoughts, both of you, on this question. Thomas Bartel, Medical University of Vienna. He's asking, was LVSI routinely reported in final histopathology and considered for adjuvant therapy decisions, or was it only diagnosed post hoc for this study? If not, what was the concordance between initial LVSI diagnosis and those determined by the pathologic re-review?
So LVSI has always been reported way before the study was initiated. So our pathologists will always report LVSI as present or absent or suspicious for LVSI. So, and decisions on adjuvant therapy, we usually do consider LVSI, particularly in stage 1 patients if we're trying to make a decision about giving intravaginal brachytherapy. Now, what we did in this study is we took patients with suspicious or LVSI and then re-reviewed them and classify them. So we did not take the patients who had no LVSI and reviewed them to see if we missed LVSI. So this is a question that's fair to ask. But we felt that since expert GYN pathologists were the only people who are making the diagnosis in our department for the last 2 decades, we felt that we should only focus on the patients who had suspicious or LVSI to start counting those vessels.
And if I can add that whenever there is a suspicion for LVSI, our pathologists always report it as suspicious of LVSI. So the chance of missing an LVSI is very, very slim. And I believe there was a part that in the question that what was the concordance between the initial and the reread. For the suspicious LVSI, there was 9 total patients with suspected LVSI, 6 out of which were thought to be mimickers on re-review. 2 had focal LVSI, and only 1 had substantial LVSI on reread. So out of all the patients with LVSI, only 9 had to be reclassified.
Excellent. Very good information. Another question from Thomas. This to you, Nadeem. Peritoneal cytology is not part of the fecal staging, but was previously associated with impaired survival. Based on what data and rationale did the authors exclude patients with positive peritoneal cytology from this study?
So that's a good question, Thomas. We still believe that although washings are not in staging, but we still believe that washings are a biomarker for worse outcomes. And in the past, it was in staging. So this is an evolving topic. And in the future, it may come back to staging. So we felt to have the cleanest group, because we're looking at oncologic outcome, the cleanest group would be where cancer cells were only found in the uterus, in the fundus. So we wanted negative washings, we wanted negative lymph nodes, we wanted the cleanest group to answer this question. So that was the rationale for excluding them.
Okay. Nadeem, another question from now Stephanie Gill at the University of Toronto. And she's asking, given your findings in node-negative early stage endometrial cancer with any LVSI, either focal or substantial, will you reconsider the adjuvant treatment you're recommending now? For example, if they do not meet any of the PORTEC criteria but have substantial LVSI, will this now impact your decision to offer adjuvant treatment?
So thank you, Stephanie. Great question. So this research that we did and published last year and this year was really gave us a lot more insight about the importance of LVSI, any LVSI that's detected, regardless of the count on a single slide, particularly in patients with endometrioid cancer with lymph node negative. We really did not know that there was a threefold increased risk in this group of patients. And so that's now giving us a lot more information. But I have to say, that doesn't translate in us prescribing any additional adjuvant therapy. This is not something that was addressed with this data, but needs to be studied in the future. Because again, just because we're seeing a higher recurrence doesn't mean that automatically we need to add treatment without really studying if that treatment is going to help with that recurrence and have an acceptable side effect. So that's one caution, is that if you find in your work that you are detecting more recurrence, there shouldn't be an immediate reaction to prescribe chemotherapy or prescribe more radiation. This has to be studied. So I would caution from immediately jumping to additional treatment just because of the finding of LVSI.
Excellent. Now, turning to you, Chris, now, Julia Gellison, she's asking, why do you think BMI greater than 30 was associated with local recurrence on multivariate analysis? Were you surprised that the overall recurrence rates were the same for focal and substantial LVSI?
Thank you so much, Julia, for these two important questions. Although our study did not specifically look at the relationship between BMI and the location of disease recurrence, we were surprised to observe this association. While the current analysis does not provide a mechanistic explanation, our team is actively conducting additional studies aimed at further investigating the relationship between BMI and recurrence risk in endometrial cancer. I have to say that most data shows a paradoxical relationship between BMI and recurrence in endometrial cancer. At least for now, this from my own research and based on my own knowledge, this is the first paper that shows a positive relationship, particularly in this low-risk group. But it would be really interesting to see where this would lead. Regarding the overall recurrence rates, we were not surprised to find similar outcomes between the focal and substantial LVSI. Our hypothesis from the get-go was that once lymph nodes are confirmed negative, the extent of LVSI, whether limited to a few foci involving multiple foci, may have a limited additional impact on overall recurrence risk. However, the presence of any LVSI remains a marker of biologically aggressive tumor, and the observed similarity in recurrence rate between a focal and substantial likely reflects the shared underlying risk.
Now, Chris, Christian Brown also asking, in this study, patients with focal LVSI were more likely to experience local recurrence. Those with substantial LVSI had higher risk of distant metastases. Despite similar adjuvant therapy rates, what biological mechanism is to explain this difference?
Really important question. Interpreting adjuvant treatment, like Dr. Abu-Rustum has said before, in this study is inherently challenging, given the extended time frame over which the cohort was assembled, which was a period marked by evolving treatment guidelines, and perhaps more importantly, considerable variation in institutional practices. In theory, one might expect to see lower rates of local recurrence in patients with focal LVSI group, which largely received intravaginal brachytherapy, and reduced distant recurrences in the substantial LVSI group, which were more often treated with chemotherapy. However, the observed pattern, which is higher local recurrences in the focal group and higher distant recurrences in the substantial group, raises the question of whether current treatment strategies are adequately tailored. That said, like Dr. Abu-Rustum has said before, we caution against drawing any conclusion in that regard. These findings are simply reflect the underlying biology of the disease and suggest that in the absence of treatment, recurrence rates could have been even higher. And what we are just seeing is a post-treatment effect. Given the retrospective nature of the study, it is impossible for us to definitively assess the treatment effect or causality in this case.
So these last two questions I'll direct to Nadeem. The first one is actually from multiple fellows, the same theme in that question. And they asked, the study suggests that the FIGO 2023 classification may not accurately differentiate between patients with focal LVSI and those without. What modifications to the classification system should be implemented to better reflect the probability of disease recurrence?
It's an excellent question, and it's really at the heart of this entire discussion, because our concern is that with the current definitions, patients with no LVSI, with 1 vessel, 2 vessel, 3 vessel, and up to 4 vessel LVSI, which in many manuscripts 3 and 4 vessel were considered extensive and substantial, all of a sudden now are all put into a low-risk group, which is not supported by this data. This data clearly says that you cannot put patients with 3 vessel, 4 vessel, 2 vessel, even 1 vessel in the same category as no LVSI. So I think hopefully this data will help the endometrial cancer subcommittee of FIGO to give them more information about how to allocate or put LVSI into any staging or predictive model. And it's not unreasonable to say that LVSI is a definite biomarker for recurrence, but may not necessarily need to be in the staging system. Like we do with washings, we say describe washings, but it's not in the staging system. So this is for the future to be determined by guidelines throughout the world, by staging committees throughout the world. So I think this is an important piece of data that hopefully will help in the future.
Excellent. And as a last question, they ask, your study highlights a 3-fold increase in recurrence risk associated with LVSI. Given that high tumor grade and deep myometrial invasion are also independent prognostic factors, how do you envision the role of LVSI in future risk stratification models? Should it be considered as a primary risk factor or in combination with these other parameters?
Again, an excellent question. I think at this moment, we should not look at LVSI in isolation. LVSI should be looked at as part of a larger group of uterine risk factor, namely deep myoinvasion, and again, grade. So like many things we do with endometrial cancer, we try not to look at things in isolation. These things should be put all together. And I think if you are trying to create a prediction model, clearly LVSI, like if you're building a nomogram in the future, clearly LVSI should be included because it's a powerful biomarker, but would not look at it in isolation. And as Chris said, and as the data says, myoinvasion, grade are also incredibly important for recurrence.
Well, I want to thank you both, Chris. Once again, congratulations on so much hard work, dedication, obviously gathering all of this data, multiple institutions, many authors, while still actually obviously playing a role of a fellow. So congratulations again. And Nadeem, of course, obviously always great to speak with you, great to see you. Thank you once again. I speak for the whole community of gynecologic oncology for all the contributions you have made and continue to make in our field. Thank you.
Thank you so much,
Thank
Pedro,
you so much,
for giving us the opportunity. And thank you so much for what you've done with the journal and your leadership and giving us the platform to have this discussion. Thank you so much.
Thank you, Dr. Ramirez. And shout out to my co-residents who are covering for me right now. All right.
Bye-bye.
Bye.